Hi, good evening. Good evening, everyone. So, this is the last session, so I'll try to go and we'll discuss the important things which you need to know in these topics: hernia, head and neck, transplant, and urology. Details of the things we will not go into because of the time, this thing. So, just see, you will get these slides also and the recorded lecture also. So, let's start. In the hernia, see, the important thing is, first of all, you need to know the European Hernia Society classification. Okay, there is classification for inguinal hernias, for incisional hernias also. Recently in the AIMS there was question also. So P is if it is primary, R is if it is recurrent, L means it is lateral, that is indirect, medial is direct, and femoral is femoral. And the defect size based on the, like this 1, 2 and 3, based on how much is the defect size of the hernia. Okay, if it is less than 1.5, 1.5 to 3, and more than 3. Okay, so in direct or indirect, this is about the defect size. Okay. And see, not all case of inguinal hernias, they need surgery. Okay, not all case of inguinal hernia needs surgery. Which hernia always required surgery? Femoral hernia. Remember, femoral hernia, always surgery. No matter complicated, uncomplicated, you will go for surgery always in femoral hernia. In inguinal, if it is uncomplicated, you can go for surgery or you can avoid surgery also. Okay, so let's see the next thing. Triangle of doom and triangle of pain is another very important question which you need to know. Laparoscopic hernia surgery. See, lap hernia surgery is one of the very important topic of hernia, lap hernia surgery. For inguinal hernia, we will do TAPP and TAP. Okay, I hope you know transabdominal preperitoneal and total extraperitoneal. So when we do this incisional hernia surgeries, when we do this inguinal hernia surgery, laparoscopic, then certain things, see, like in cholecystectomy, lap is the standard of care. In hernia, it is not yet the standard of care, but lap hernia surgery is preferred in bilateral hernias, recurrent hernias, and in case of females. So remember, in these cases, lap is preferred. Otherwise, it is patient's preference whether they want to undergo lap surgery or open surgery. But in these three cases, lap is preferred over the open surgeries. Okay, so when we do these surgeries, certain landmarks which you need to know: triangle of doom, very important, vas medially, gonadal vessel laterally, and this is the peritoneal reflection. Okay, triangle of doom is one very, very important question. And this triangle of pain, it is just adjacent, just lateral to the triangle of doom, which is bounded by this iliopubic tract, and this is peritoneal reflection. So you can say gonadal vessel is a common boundary between triangle of doom and triangle of pain. Okay, so triangle of pain, the importance is there are important nerves here. Okay, lateral cutaneous, lateral femoral cutaneous nerve, anterior cutaneous nerve, femoral branch of genitofemoral, and femoral nerve. So these are the important nerves, and this is external iliac vessels are in the triangle of doom, nerves are in triangle of pain. So basic thing is, while doing the surgery, when we put the mesh fixation device, that is tacker should not be fired in these two triangles. Okay, because in one doom it can cause bleeding, in triangle of pain it can cause severe post-op pain because of the, you know, the pin goes on the nerve, it can cause severe post-operative pain. Okay, another important thing which you need to know in this laparoscopic surgery is this corona mortis. Okay, corona mortis, this is abnormal obturator artery. This is abnormal obturator artery which comes from the inferior epigastric. So if this is there, and if you don't identify this during the surgery, you put the tacker on this, it is going to bleed. Okay, so these are the important things you need to know in the laparoscopic surgery: TAP, TEPP, triangle of doom, triangle of pain, corona mortis, and lap is preferred in those cases which I told you. This was the question asked in the AIMS exam. This is European Hernia Society classification of incisional hernias. Okay, of incisional hernias. Now how to remember? See, suppose this is umbilicus. This is umbilicus. You draw 3 centimeter above, 3 centimeter below. Okay, in this, I guess, should draw like this. Suppose this is umbilicus, this is xiphisternum, this is pubic symphysis. Okay, 3 centimeter above, 3 centimeter below. Draw a line From pubic symphysis, again 3 centimeter above, from here 3 centimeter below. Draw the line. Okay, this is how you remember this. Okay, so this will be M1, M2, M3, M4, M5. 3 points. Just remember xiphisternum, umbilicus, and pubic symphysis, and 3 centimeter. Okay, so this is the subxiphoid. M1 is subxiphoid. This is epigastric. M3 is umbilical. Spigelian. This is basically suprapubic. Okay, suprapubic. This is infraumbilical. Okay, M4 is infraumbilical. Infraumbilical. And just laterally you have L1, L2, L3 and L4. L1, L2, L3 and L4, this is present laterally. Okay, so this is, again I'll show you in another picture. This is midline and lateral. This is, already they have asked questions, so remember these things, M1, M2, M3, M4, M5 and L1, L2, L3, L4. Depending on the width, it is W1 if it is less than 4 centimeter, W2 if it is more than 4 to 10, and W3 if it is more than 10 centimeter. This is the defect size basically. So European Hernia Society classification is something very important. This is for primary ventral hernia. This is not that important. So just remember for the inguinal hernias and for the incisional hernias. Okay, inguinal hernia and incisional hernia. Now this thing in incisional hernia, when we do the surgery, the position where we put the mesh, that defines whether it is overlay. Overlay is when it is present above the rectus. Inlay is when it is bridging the gap. Sublay is below the rectus. And IPOM or underlay is when you put it below the peritoneum. Okay, so if they ask which is having most recurrence, inlay is having maximum recurrence risk. Okay, maximum recurrence risk. Sublay is, you can say sublay is the gold standard. IPOM and underlay, this is done in laparoscopic surgery. In lap hernia, I mean this is lap ventral hernia, incisional hernias or ventral hernia, we will do this. Okay, in lap hernia, IPOM is done. Intraperitoneal onlay mesh repair, and this is a type of underlay repair. So when you are using this IPOM or underlay, then you use a composite mesh. Composite mesh which is bilayered. Okay, so that the undersurface which is going to come in contact with the intestine, it should not, the intestine should not get stick to it. So you use a composite mesh where one layer which is going to face the intestine, that is made up of either there will be some collagen covering, there will be some there will be oxidized regenerated cellulose covering, there can be PTFE covering, so that is composite mesh. Next thing, see sometimes when there is very large ventral hernias, okay, large ventral hernias including incisional hernias, in that there is loss of abdominal domain. Okay, when the defect is more than 10 centimeter or when in the hernia sac more than 50% of the intestine is in the sac, intestine is in the hernia sac, then it is very difficult to close the abdominal wall. Okay, so in those cases what we follow is we follow component separation. Very, very important, and there are very high chances they ask question on this component separation technique. Okay, component separation technique is, see these are the abdominal wall layers. This is external oblique, internal oblique and transversus abdominis. So here, because in the midline the rectus is not coming, so we will move the lateral layers on each other. So you can see here we divide the external oblique from here and then we pull this towards the midline. So while doing this on both the side, we can cover a gap of 18 to 20 centimeter. Okay, this much gap can be covered. So this is component separation technique, also known as Ramirez surgery. Okay, this is component separation. So this is anterior component when you are separating the external oblique. If you separate the posterior part, okay, when you separate the, see just here I will tell you, if you separate like this here, transversus abdominis, then it is known as transversus abdominis release, TAR. Okay, so TAR is also a type of component separation. This is posterior component separation. Posterior component separation, TAR. Okay, so that is Ramirez technique, anterior component. This is posterior component for large hernias. One more thing in hernia, you remember, this is This is the defect. Just concentrate on this A. Okay, so when we do this Roux and Y type of gastrojejunostomy, like in case of bariatric surgery, the gap between this Roux limb and this intestine and the other alimentary limb which is coming. So this defect is known as Peterson defect, and that hernia is known as Peterson hernia. Okay, so this is Peterson hernia. If it occurs between the mesenteries of these two loops of the jejunum. Okay, one loop is this, which is the biliary loop, and one loop is this, which is going here. This is the, you can say, the alimentary limb through which the food is coming. So between these two mesenteries, if the herniation occurs, that is Peterson hernia. And if the herniation occurs through this defect in the mesocolon, then it is known as Stammer's hernia. Stammer's hernia. Okay, so remember these two internal hernias which can be seen. So these are acquired, and you can say post-surgery these hernias can be seen. So that's why when we do the surgery, we try to minimize this space by doing the suturing. We just leave only that much space through which only intestine can pass. This is omphalocele. This is very important image-based question. Okay, omphalocele, you get the image something like this, and then they ask something that what is the diagnosis. Most of the time they ask this only. It is covered by a membrane, and the congenital anomalies are more in omphalocele. On the other hand, this is gastroschisis, which is not covered by anything, but the prognosis is better because the congenital anomalies are less in these cases, in case of gastroschisis. Something like this abdominal wall defect, you can get a picture like this. Okay, so this is infraumbilical. Okay, remember in that the defect is at the level of umbilicus. Here the umbilicus is absent, it is defect. In this case, defect is mostly towards the right of the umbilicus, and this is below umbilicus. Okay, so this is ectopia vesicae or extrophy of the bladder. Ectopia vesicae or bladder extrophy. So you have to differentiate these three things, anterior abdominal wall defects, in like this will be a image based question. This is congenital diaphragmatic hernia. Okay, again two important things you need to know. Bosdalek hernia is one, and Morgagni hernia is one. Okay, so Bosdalek hernia this is a more common type of hernia, Bosdalek hernia, and the defect is posterolateral. And mostly the patient will have, the child will have symptoms here. Morgagni is right side, anterior, and most of the time the defect is small and asymptomatic. Many times it is not diagnosed even at the adulthood. Later on it can be diagnosed, and sometimes it goes undetected for the whole life also, Morgagni hernia. Okay, so it is the Bosdalek which is more common in congenital diaphragmatic hernia. Okay, levels of lymph node, I hope you know, level 1 to 7 is there. Okay, but I want to tell you there is a new term which they have introduced, that you know what is radical neck dissection, what is modified radical neck dissection. In radical we remove level 1 to 5, as well as we remove sternocleidomastoid muscle, internal jugular vein, and cranial nerve 11. In modified radical neck dissection we only remove the lymph nodes, the nerve, muscle, and the vein is preserved. So these days there is a new term for that, that is known as comprehensive neck dissection. Okay, so remember comprehensive neck dissection. So this is done for node positive patient. If there is lymph node involvement, when the lymph nodes are enlarged. Okay, when the lymph nodes are enlarged, it is, we do comprehensive neck dissection, either radical or modified radical. Elective neck dissection is another term which is used for selective neck dissection. This was the older term, selective neck dissection. So this is done for N0 patient. When clinically the patient, the lymph nodes are not enlarged, but somehow the natural history of tumor says that the lymphatic spread, the chances are quite high. So prophylactically we remove few group of lymph nodes, so that is known as elective neck dissection. Okay, so elective is basically a type of prophylactic. Depending on which tumor we can do different types, like for cheek cancer we'll do supraomohyoid neck dissection, for tongue cancer we'll do extended supraomohyoid. Okay, for pharynx larynx cancer we'll do lateral neck dissection. So that depends on which cancer we are talking about. Depending on that we will do this elective neck dissection. Another thing, somebody just asked what are the important TNMs. Okay, in head and neck and urology part I will tell you the important TNMs. The details of TNM, okay, you know, you also understand that we cannot discuss here. But oral cavity cancer, This is very important TNM, because already there are questions directly on the TNM. There are certain TNMs which you need to know the treatment basically. Here questions are directly on TNM, and there are recently changes. Okay, so I'll just tell you the important things. Oral cavity cancer, previously it was very easy. This red line is the 7th edition. Just see, less than 2 centimeter. Here 2 to 4 centimeter, more than 4 centimeter. So this was there in the last, the 7th edition AJCC. Now what they have added this depth of invasion. So after the adding of this depth of invasion, it becomes slightly, complicated. So this you need to know. Depth of invasion is the new addition, and that makes TNM a bit complicated, but this is at the same time, this is very important, as important as breast cancer. So you have to know this classification. T4A, which was previously known as operable, now they call it as moderately advanced. T4B, which was known as previously inoperable, now they call it as very advanced. Okay, so this is T staging. Nodal staging, not much changes has been done in the recent. The only change they have done is they have introduced this N3B. Okay, they have introduced this N3B, which is extra nodal extent. ENE is when the tumor is going outside the capsule of the lymph node. Okay, so that is extra nodal extent. Otherwise, rest of the nodal staging is same as the previous staging. Okay, so N1 is single ipsilateral lymph node less than 3 centimeter. N2 is further divided into 2A, 2B and 2C. 2A is more than 3 but not more than 6. 2B is when there are multiple. 2C is when there is bilateral or contralateral. And N3 is any lymph node which is more than 6 centimeter. And from N1 to N3A, all the lymph nodes, the tumor has not gone beyond the lymph node. And in N3B, it has gone beyond the lymph node, that is ENE positive. Okay, so this is one staging which you need to remember. Okay, so that is the TNM staging. Based on that, there is stage 1 and 2, 3, 4. So here you see stage 1 and 2. What is the treatment principle? So these are the treatment principle for all these oral cavity cancers. For stage 1 and 2, we'll use single modality treatment, either surgery or radiotherapy. Okay, either you do surgery or radiotherapy. Surgery is preferred, but you have to go for any of these. And in stage 3 and 4, you have to do surgery as well as you need to give post-op radiation. Chemo may or may not be added, although these oral cavity cancers are not much chemosensitive, but still there are lots of people, they are adding chemo these days. Okay, so remember this thing. This is the general principle of this lip cancer or cheek cancer, tongue cancer. Stage 1 and 2, single modality. 3 and 4, go for multi-modality. And when we do the surgery, see, so surgery, important thing is how much margin we should take while doing the surgery. Like for lip cancer, the margin is 3 to 5 millimeter. Okay, 3 to 5 millimeter. Minimum 3, 5 is ideal. For cheek or the buccal mucosa, 10 to 20 mm. Okay, 10 is the minimum margin, 20 should be the ideal, 20 is 2 centimeter. And for tongue also, the same thing. Okay, so remember this margin. Another important thing which you need to know in the treatment of these cancers is in lip, if it is an node involvement, okay, go for comprehensive neck dissection. If it is N0 disease, you follow up. Okay, there is no need of going for a elective neck dissection in lip. But in case of cheek, if it is node positive, go for comprehensive neck dissection. If it is N0, go for elective neck dissection. So in these cancers, you have to do some surgery for the lymph node depending on the status. If it is involved, go ahead and do the comprehensive neck dissection, either MRND or radical. But if it is not involved in cheek and tongue, then also you go and do the surgery. In cheek, you will do supraomohyoid neck dissection. In tongue, you will do extended supraomohyoid neck dissection. Okay, so remember this. This is a flap which they might ask as a image-based question also for lip reconstruction, Abbe-Aslander flap, okay, which is based on labial artery. So for lip reconstruction, this is used for partial. In case of total, if you want to reconstruct the total lip, then you use radial forearm flap. Okay, radial forearm flap, which is based on radial artery. Okay, this is a bare slander only. This is how it is done. This is for cheek cancer. When we do the surgery and there is a defect, we use pectoralis major myocutaneous flap, okay, PMMC flap. This is based on pectoral branch of thoracoacromial artery. Okay, pectoral branch of thoracoacromial artery, PMMC flap. These are radial forearm flap, which is used for the reconstruction of the cheek. Can be used for the partial reconstruction of the tongue when we do a hemiglossectomy like this. This is a hemiglossectomy. This is radial forearm flap. Okay, for total glossectomy, if you do total, then you use rectus abdominis flap. Rectus abdominis muscle flap for total glossectomy. For partial, you can use radial forearm flap. Okay, this is a radial forearm flap used for the reconstruction. In case where you need to remove the mandible, then the flap which is used, the best flap is free fibular flap. Free fibular graft they call it as. So this is for mandible reconstruction. In case where you have to go for a segmental mandibulectomy, free fibular graft is the best type of graft. Okay, this is how they take the free fibular graft. Okay, the next thing we'll see here, in the salivary gland, the important things which you need to know is, first of all, that what are the nerves at risk of injury during parotid surgery. Parotid surgery, the nerves facial, we all know, greater auricular and auriculotemporal. Okay, so these nerves, they get injured during the parotid surgery. Submandibular, the nerves which are at risk of injury is lingual nerve, hypoglossal, and marginal mandibular of facial. Marginal mandibular of facial. So remember this, the nerves at risk of injury. Second important thing which you need to know is, when we do the parotid surgery, the most important thing in this superficial and total parotidectomy is landmarks for facial nerve identification. Okay, landmarks for facial nerve identification. See, these are the landmarks. Posterior belly of the digastric, mastoid process can be used. We can make a hole here and then we identify the main trunk. Okay, tympanomastoid suture line. Tympanomastoid suture. Stylomastoid foramen, from where the nerve comes, stylomastoid foramen. Okay, this Conley's point or tragal pointer, and you can go from periphery to the main trunk. Okay, so these are the different, the landmarks to identify the facial nerve, and this is the most important thing which you need to do, or which you need to start in the beginning of the parotid surgery. So you preserve the facial nerve, remove the other things. Facial nerve is removed, a part of the facial nerve is removed when the tumor is directly infiltrating the facial nerve, like in case of, when there is like adenoid cystic carcinoma. Then in those cases you might need to take out a part of the facial nerve, and it can be reconstructed using sural nerve or the greater auricular nerve. This is ranula. We all know this is ranula. Now the controversy is whether this is mucus extravasation or retention cyst. Remember, it is mucus extravasation cyst of sublingual gland. Remember always this. And if it is a plunging granula, then it is a mucus retention cyst of both sublingual and submandibular gland. This is of sublingual only. Okay, now one thing which is written in the Bailey it is written that plunging ranula is operated by giving incision in the neck, cervical. Ranula is we give intraoral incision, but plunging they have written that we go by the cervical incision. That has been changed. Even for plunging ranula we go by the intraoral approach. Okay, so remember, for this also, for plunging ranula or be a simple ranula, we go by the intraoral approach. We don't go via the neck. Okay, this is cystic hygroma. Image-based question can be asked. Okay, this is large cystic hygroma. This can cause airway obstruction. Like in this case, you can see it is causing airway obstruction. Treatment options: if it is not causing any problem, we can observe also, because sometimes it spontaneously regress. Surgery is most commonly done, and sclerotherapy can also be done using bleomycin and there is a chemical which is known as piscinabil, and it is basically OK432 is the name of the chemical derived from the Streptococcus pyogenes. Okay, so these are the options. This is carotid body tumor. Okay, this is, you can see in the upper part of the neck, carotid body tumor is there. Now, one thing which you see about this carotid body tumor is, remember, there is something known as Chamberlain classification. Okay, because this is present at the bifurcation of the carotid. So if the tumor is involving less than 80 degree, okay, it is encasing the vessel less than 80 degree, it is Chamberlain type 1, 180 to 270 degree type 2, and 270 to 360 degree is type 3. Okay, so in case of type 2 and 3, many times you need to do a vascular reconstruction. You need to divide the vessel and do the reconstruction. In type 1, vascular reconstruction is usually not required. Okay, in type 1 it is not required, but in type 2 and 3, most of the time you need to do the vascular reconstruction. On carotid angiography, you will find the splaying of the internal and external carotid artery, that is known as Lyer's sign. Lyer's sign, the increased angle between the internal and external carotid, obviously because of the enlarged carotid body. Okay, this is branchial cyst. Branchial cyst and fistula both are because of the second branchial cleft, remnant of the second branchial cleft. Important thing is, branchial cyst is present in the upper 1/3 of the neck. Okay, upper 1/3 of the neck, just anterior to the sternocleidomastoid origin. And fistula is present in the lower 1/3 of the neck. Lower 1/3 is the external opening. Internal opening goes somewhere here in the tonsillar fossa. Okay, although both are congenital disorders, but the presentation is usually seen in the late 20s or early, the late teens, basically at the age of between 18 to 25 years. That is the common presentation here. Okay, so that is branchial cyst and fistula. In the thyroid anatomy, you need to know there is something known as Baer's triangle. Baer's triangle, already there are questions. Common carotid artery, inferior thyroid artery, and recurrent laryngeal nerve. Okay, so recurrent laryngeal nerve, common carotid, and inferior thyroid artery, they form the triangle. So recurrent laryngeal nerve is basically forming a boundary hair. Baer's triangle is for identification of recurrent laryngeal nerve, which is forming a boundary hair. This is Joel's triangle. So this is for the external laryngeal nerve, midline of the neck, strap muscles, and the superior pole of thyroid. Okay, midline, strap muscle, and superior pole of the thyroid. External laryngeal nerve here is the content. Okay, it is the content. It is not forming the boundary, Joel's triangle. One more thing in the anatomy, you remember, see, suppose while doing the surgery, consider this as the main artery. So we don't ligate the main artery, we ligate only the branches which are going in the thyroid parenchyma individually. Okay, the superior and inferior thyroid artery, main trunk is not ligated. Okay, you can see only the branches which are going directly, that we separately ligate, because the main trunk also supplies to the parathyroid. So if you divide the main trunk, parathyroid ischemia might occur. So that's why just those branches which are going in the thyroid directly you ligate. Thyroid, the most important thing which you need to know is solitary thyroid nodule. Okay, this is one of the very important thing. Solitary thyroid nodule, investigation of choice is FNAC. Okay, but this is not the first investigation. Initially you will get the thyroid profile, and then depending on, like, if the patient is hyperthyroid, then you go for thyroid scan. If the patient is hypo, then you go for ultrasound. Okay, so on scan you can get hot nodule, cold nodule, or warm nodule. Hot, cold, or warm. Hot nodule, you start the patient on the anti-thyroid drugs, or you can go for hemithyroidectomy also, or ablation. Okay, either drugs, ablation, or surgery. Mostly surgery is not required. Cold and warm will be treated as a hypothyroid or euthyroid. Okay, so I'll tell you the important questions. Ultrasound, when you do the ultrasound, it will tell you the size. Now, not all the cases we go for FNAC. So what is the cutoff size for FNAC? Cutoff size for FNAC. Okay, ultrasound will also tell you whether this is a solid nodule, whether this is a solid as well as cystic, and whether it is spongiform. Spongiform means mostly there are liquid part, and mostly there is solid, mostly there is liquid part, little bit of solid component is there, or if it is completely cystic. Okay, this is important. Solid 1 centimeter. More than 1, go for FNAC, less than 1, follow up. Solid plus cystic 1.5 centimeter. Spongiform 2 centimeter. And if it is completely cystic, FNAC is not indicated. Okay, so remember this cutoff size of FNAC, which you get, the size, exact size you will get on the ultrasound. Okay, and ultrasound, okay, that I will discuss later. So after FNAC, this is what you get. These are the features. This is known as Bethesda classification. Okay, Bethesda system or Bethesda classification is this. Now there is something known as European classification. So that is also there. Just see this as per the European, this is Thigh 1. Benign is Thigh 2. ATP of unknown significance or follicular lesion of unknown significance is Thigh 3A. Follicular neoplasm is Thigh 3F. Suspicious is Thigh 4. Malignant is Thigh 5. Okay, so this is another classification, and there was a question also, so that's why I'm telling you, you don't need a separate classification. Just in this also, in this only, you just write what is Thigh 1, Thigh 2, Thigh 3A, 3F, Thigh 4, and Thigh 5. Okay, now see, if it is non-diagnostic, follow up. If it is benign, again you follow up, or you do surgery if the patient's preference is there, or if there is compressive symptoms. You all know when there is compressive symptoms, we need to do surgery. ATP of unknown significance, here you can repeat FNAC also if it is non-diagnostic, preferably ultrasound guidance. In this you have multiple options, either follow up or repeat FNAC, or go for something known as molecular diagnosis, where you use different markers like P53, BRAF mutation, and this RET mutations. These mutations you will see. Or here also you can go for surgery if it is if you are not coming to any diagnosis. In suspicious and malignant, definitely you go for definitive surgery. Definitive surgery means this is not for the diagnosis. Diagnosis already you have. This is a curative surgery. In this case, when it is follicular neoplasm, FNAC cannot differentiate between a follicular adenoma and carcinoma. So here you will go for a hemithyroidectomy. Hemithyroidectomy, which is also known as lobectomy. This is done first, and then you send the sample for histopathology, and they will see vascular and capsular invasion. If it is there, then it is cancer. If it is not there, then it is adenoma. Okay, so hemithyroidectomy is done here. So this is one very, very important thing which all of you should know, because there are very high chances that you will get a question on this. This is a hot nodule on the radioiodine scan. This is a cold nodule on the radioiodine scan. This is the ultrasound feature of a malignancy. This is black. It means it is hypoechoic, taller than wide. Okay, and there will be microcalcification can also be seen, increased vascularity, architectural distortion. Okay, so these are the different things. Based on that, there is something known as TIRATES also in thyroid. Okay, thyroid imaging reporting and data system based on the ultrasound features of this thyroid gland. This is one thing, again, in the post-op period, if there is a hematoma, then the patient will present with stridor. Remember, what is the treatment? Open the wound immediately. Open immediately, relieve the obstruction, and then you shift the patient to the OT and then do the surgery, control the bleeding. You have to open the wound on bedside only, otherwise the patient might die while reaching, or before reaching to the OT she might collapse, because airway obstruction is something which you should take very seriously and very urgently. This is lateral aberrant thyroid. Okay, again another important question, lateral aberrant thyroid, which is a lymph node metastasis. Okay, this is a lymph node metastasis from occult papillary thyroid cancer. Occult, it is, the thyroid here looks normal, absolutely normal. Maybe the cancer is less than 1 centimeter and it is not yet evident, and patient can have this lymph node metastasis, so that is known as lateral aberrant thyroid. Remember, this is Samoma bodies. These are orphan NEI nuclei. Okay, so these are the important pathological findings in the papillary thyroid cancer. Okay, this is amyloid stroma, which is seen in medullary thyroid cancer. So these two histopath slides you remember for thyroid malignancies. Clinical tests are also important. Recently there was a question. This is Pizzillo methods, when usually done in small things. This is Cocker's, when you push with one hand and with the other hand you palpate. Okay, this is Cocker's test, which is done to see whether the patient is having skybarred trachea. This is Kreil's method for small swelling. You put the thumb and then see the movement. This is Trail sign to see the midline of the trachea. This is Pemberton sign, which is used for the retrosternal goiter. Retrosternal goiter. Okay, this is SESTA-MIBI scan. Again, there is some controversy that what is the investigation of choice for parathyroid adenoma. It is SESTA-MIBI. Okay, this is the investigation of choice. It can be combined with a SPECT, a single photon emission CT scan. So SESTA-MIBI with SPECT, that gives a better image. But yes, SESTA-MIBI is the investigation of choice. There should be no doubt about it. Okay, there are because people they are saying that maybe 4D CT is the investigation. 4D CT is a good investigation, but not yet the investigation of choice. Okay, one more thing here in the thyroid cancer. Just see what is the treatment for differentiated thyroid cancer. Remember, differentiated thyroid cancer is a term used for papillary thyroid cancer and follicular thyroid cancer. Okay, so these days, based on the prognostic criteria like AMIS, AGIS and MACIS prognostic criteria, not in all cases you need to go for total. Total you will do if the size is more than 4 centimeter, age more than 55. Remember these things because there are questions on this. If there is any distant mets, if there is extrathyroidal extent, if there is lymph node mets, if on biopsy it is poorly differentiated, if there is prior radiotherapy, or if there is bilateral nodules. So if any of these things is there, then you go for total. And then you can see Hemi will do in what cases. Just write the opposite of this. Okay, a size less than 4, age less than 55, no distant mets, no extrathyroidal extent, no lymph node metastasis, well differentiated, no radiotherapy, no bilateral nodule. So in those cases, if all present, then you go for hemithyroidectomy. Okay, so hemithyroidectomy is a established surgery for the thyroid cancers, especially papillary and follicular thyroid cancers. Okay, and in papillary thyroid cancer and follicular thyroid cancer, if lymph nodes is involved, go for comprehensive neck dissection. If it is not involved, follow up. And this is what is difference in medullary thyroid cancer. Medullary thyroid cancer, first thing is you will go for always total. There is no hemi in medullary thyroid cancer. And if lymph nodes are involved, go for comprehensive neck dissection. If it is not involved, then also you go and remove level 6. Okay, so level 6 is routinely removed in medullary thyroid cancer. So this is one thing which I want to tell you. And one more thing is that medullary thyroid cancer does not take up radioactive iodine. So this is the RAI ablation is not helpful in medullary thyroid cancer. Okay, and follow up in differentiated thyroid cancer. What is the first thing you will do? First thing you will do is TSH suppression. TSH suppression. Keep the TSH less than 0.1 in high risk cases, less than 0.5 in low risk cases. Then you check the serum thyroglobulin level. If it is more than 2 nanogram, then it means there is either recurrence or there is residual disease. Recurrence or residual disease. Then you do the radioiodine scan. So this is by this you will know what is the site Okay, you will know what is the site of the recurrence or residual disease, and if it is operable, go for surgery. If it is inoperable, then you will see how is the uptake. How is the uptake? If it is good uptake, then go for RAI ablation. If poor uptake, then go for external beam radiotherapy. Okay, so this is how you do follow-up. When you do ablation here, the dose of the iodine 131 is more. It is approximately 30 to 100 millicurie. Okay, 30 to 100 millicurie is the dose. In benign cases like in Graves' disease, we use 8 to 12 millicuries. 8 to 12 millicuries we use in case of like Graves' disease. Okay, so in parathyroid, the important thing which you need to know, investigation of choice we have seen. Indication for surgery. This is one of the most important thing in parathyroid adenoma. Okay, either the patient is symptomatic or in asymptomatic, if the age is less than 50, if the GFR is low, decrease, that is less than 60, if there is decrease in the bone mineral density, or if the serum calcium is more than 12 milligram per deciliter. So remember, this is one of the very, very important things which you need to know in the parathyroid. Now when you do the parathyroid surgery, see, parathyroid glands, they are very small. Even if they enlarge, they are still, like, as compared to the other things, they are quite small. So when you remove the parathyroid, these days you give very small incision. So when you remove the parathyroid, how will you make sure that the gland which you have removed is parathyroid only, not something else? Because there can be fat globules also there, lymph nodes is also there. So confirmation is done most commonly is when the serum PTH drops by 50% in 10 minutes after the surgery. So I want you to remember this. This is known as Miami criteria. Miami criteria, when the serum PTH drops by 50% in 10 minutes. Otherwise, other options are frozen section is there, intraoperative ultrasound can also be done, but this is what is most commonly followed. Okay, in FEO, the things which you need to know, initially it was like 10% of the pheochromocytoma are familial, now it is 25%. I hope you know 25% are familial, not 10%. Second thing is about the investigation. There is some controversy that when to go for plasma metanephrine and when to go for urinary metanephrine. Okay, plasma and urinary metanephrine. Plasma metanephrine is used for the high risk cases because this is more sensitive. Urinary is used for low risk cases because it is more specific. Okay, high risk cases are like when the patient is having these any family history, all these syndromes which are there, Men's syndrome, von Hippel-Lindau syndrome, neurofibromatosis syndrome, familial paraganglioma syndrome, or personal history. Suppose patient had a pheochromocytoma on one side in the past, now again he has come with some kind of swelling in the other side. So in those cases, go for plasma. And these are, if these things are not there, then it is low risk, go for urinary metanephrine. When there is no family history, no syndromic association, and no personal history. Okay, and radiologically also, see, the first investigation when you suspect pheochromocytoma, go for CT scan. If not identified, go for MRI, which is the investigation of choice. On CT, if you can identify, there is no need of doing MRI. Both CT and MRI cannot identify, then go for meta-iodobenzyl guanidine scan, which is a radionuclear scan. Okay, so that is for MIBG scan, only if CT and MRI is not helpful. Okay, Men's syndrome. See, in Men 1, the important MCQs which you should know is, what is the most common pancreatic neuroendocrine tumor? Okay, it is non-functional. Most common functional pancreatic neuroendocrine tumor is gastrinoma. Gastrinoma. Most common pituitary is prolactinoma. Okay, so these are the important things here. Now, something about the transplant. I'll just tell the important things which you need to know in the transplant. Maastricht classification is one which is used for non-heart beating donor. Okay, this is for non-heart beating donor. In 1, 2 are uncontrolled, 3 and 4 is controlled, 5 is also uncontrolled. So this is for non-heart beating donor. This is very important, Maastricht classification. Then for acute liver failure, acetaminophen induced and non-acetaminophen induced, this is King's College criteria. Okay, so I'm telling you the important things. Okay, so details we cannot cover, it is not possible, just important things which you should know. King's College criteria. Okay, Milan's criteria, Tiwari sir has already discussed. Single lesion less than 5 or up to 3 tumors less than 3 centimeter. Okay, MELD score, just see serum creatinine, bilirubin and INR, CBI. Okay, now what is the importance of MELD? If the MELD is more than 15, patient is a candidate for transplant. This is, remember, for liver transplant, MELD more than 15, candidate for transplant. Okay, so basically how we set the priority in liver transplant. Priority in liver transplant. Okay, priority in liver transplant. MEN2, basically the only thing which you need to know about the MEN2 is when to do the prophylactic thyroidectomy. In MEN2A, do it within 1 year, preferably between 6 to 9 months. And in MEN2B, do within 6 to 9 months. And in MEN2A, do at the age of 5 years. Okay, this is what you need to know about MEN2. First is, there is something known as status 1. Then MELD 35 to 40 and then MELD 15 to 34. So this is the priority. Now what is status 1? Status 1 is acute liver failure and there is something known as primary non-function of graft. Primary non-function of the graft is when you do the liver transplantation and after the transplant everything, like technically everything is fine, but the liver is not working. That is known as primary non-function and that is basically status 1. Status 1 is topmost priority. Topmost priority. Okay, now in the liver transplant, see, this is conventional technique. Conventional technique is, just see, suppose this is the liver which you get from the patient, from the donor. So question is asked, what is the order of anastomosis? Now you have to put this in a recipient's body. So what is the order of anastomosis? First you anastomose this suprahepatic vena cava, suprahepatic IVC, then infrahepatic IVC, portal vein, hepatic artery, and in the end bile duct. Okay, so this is the order of anastomosis in liver transplant. Remember this, already there are questions. Okay, piggyback technique. What is piggyback technique? Piggyback technique is, in this case, the recipient's IVC is intact. Okay, recipient IVC is intact. The transplant is done based on the hepatic vein. Hepatic vein is used for anastomosis. Just remember this much about piggyback. Hepatic vein is used for the anastomosis. Recipient IVC, we do not divide or do not do anything for that. Okay, split liver transplant is when one bigger part you give to the adult and the smaller part you give to the pediatric patient. So from one liver, 2 transplants can be done. That is split liver transplant. This is known as auxiliary liver transplant. Auxiliary liver transplant is when you don't remove the native liver. Okay, suppose this is the native liver remnant. This you don't remove because there are chances of improvement in this liver. So this you keep it intact. You put the graft here in addition to that. So when this native liver recovers, then you can remove that part which you have placed. Okay, so that is auxiliary liver. You can see this is the native liver and this is the transplanted liver. which you can. So this is the auxiliary, means this is going to support the body till the native liver recovers. Okay, till the native liver recovers, this will support the the patient's body. Sequential technique, which is also known as domino liver transplant. Okay, this is done in case of familial amyloidosis polyneuropathy. So this is, suppose this is a new liver, this you give to the patient who is having FAP, and this FAP liver you give to another patient who is more than 60-year-old. I mean, the life expectancy is not much. So this FAP liver, although it is deceased, but it can take care of the patient for 5 to 10 years, and that is good enough for a patient who is already elderly, whose life expectancy is less. So we can give the liver to that patient. That is domino liver transplant. This is a kidney transplant. Just see, it is heterotopic. It is not placed at its normal site, and the anastomosis is done with the external iliac artery and external iliac vein. Okay, this is a heterotopic transplant, external iliac artery and vein. This is pancreas transplant. In pancreas transplant, because there are two vessels, so you can use a Y vascular graft, which is taken basically from the common iliac artery, external iliac artery, and this is internal iliac artery. This you can take from the donor, and then you can do the anastomosis with this, so that when you go inside the body, you have to do only one anastomosis instead of two different anastomoses. Okay, so this you need to remember about the pancreas transplant. There are three types: simultaneous pancreas and kidney, pancreas after kidney, and pancreas transplant alone. This is the most common type when you do simultaneous pancreas and kidney transplant, which is done basically for the diabetes mellitus, type 1 diabetes. Okay, so this is how the pancreas is placed. This is also heterotopic. This is not placed at its normal site. Small intestine transplant, one important thing here I will tell you. The most common reason is mesenteric ischemia. So when there is mesenteric ischemia or gastroschisis in the pediatric age group, when there is short bowel syndrome, then patient is on TPN. Okay, so that is the initial treatment of short bowel syndrome, total parenteral nutrition. So what is the indication for transplant is patient is on TPN. Because of TPN, there is overt or impending. There will be one question from this. This is my gut feeling that you will get one question from small intestine transplant. Indications: overt or impending liver failure because of parenteral nutrition associated liver disease. If it is there, or if there is multiple thrombosis of central veins. Okay, if there are more than 2 episodes of central line associated bloodstream infection. Central line associated bloodstream infection. Islet cell transplant is done in cases we'll take the concentrate and we inject into the portal vein, but islet cell transplant is not very popular because for one successful islet cell transplant you need at least 3 to 4 pancreas, so that much concentrate will make a patient insulin free, so that's why it is not very popular. Single episode of fungal infection. Okay, this is central line associated bloodstream infection, which is mainly caused by Staphylococcus epidermidis. And if there is frequent dehydration episodes despite patient on TPN. Okay, so this is something which I want you to remember. There will be a question in which of the following small intestine transplant is indicated. Okay, this is important. Heart transplant, again the order is first you anastomose the left atrial cuff, which is having opening of pulmonary arteries. Then you anastomose SVC and IVC, then pulmonary artery, and in the end aorta. Okay, so this is the order of anastomosis. The most common indication of heart transplant is ischemic dilated cardiomyopathy. Now, lung transplant, again there is some controversy. People, they ask what is the order. Remember, bronchial anastomosis first, then pulmonary artery, and then pulmonary vein. Okay, just remember BAV. Okay, because 2 times there is question on this, what is the order of anastomosis in lung transplant? Bronchial, pulmonary artery, pulmonary vein. Okay, so now we'll see in the urology, main thing is in urology you need to know about the urological malignancies. So RCC, I will not say the staging is important, but the treatment is, see, if it is a T1 tumor, okay, T1 tumor, you can go for partial nephrectomy. And in which other case partial can be done? In case of T2 to T4, if it is a bilateral tumor, if there is a single functioning kidney, or if there are familial syndromes like VHL syndrome and other syndromes. So in these cases also partial can be done. Otherwise, T2 to T4 radical nephrectomy is done, radical nephrectomy. And remember, adrenal is not removed in all cases of radical, plus minus adrenal I'll write. Adrenal is removed only if it is involved. Otherwise, previously it was guidelines that adrenal you have to remove in all cases, but now adrenal is not removed routinely, it is removed only if it is involved. Okay, so these are some of the syndromes which are associated with RCC. VHL syndrome, BAP1 mutant disease, SDH associated kidney cancers, hereditary leiomyomatosis and RCC syndrome, hereditary papillary cancer, Burt-Hogg-Dube syndrome, tuberous sclerosis, Cowden. So remember these syndromes, hyperparathyroidism, jaw tumor syndrome. There are questions on this syndrome. In AIMS there was a question on this syndrome. Okay, now the staging in the urology, which staging which you need to know, that is prostate cancer. Okay, prostate cancer is one where I'll suggest that you should remember the staging. T1 is clinically inapparent. Okay, so that is seen after the BPH you have done surgery, and if less than 5% of the specimen, it is T1A. More than 5% of the specimen is having features, T1B. T1C is when you have done the biopsy because of increased PSA. The tumor was not palpable. T2 is palpable and limited to the prostate. T3 is it has gone outside the prostate, outside the capsule or into the seminal vesicle. And T4 is when it goes to the adjacent structure. No need to remember the nodal and the M staging, just remember this much about the staging. Okay, this PDF which I am writing, the whole thing you will get. I mean, with my the things which I am writing, that is also you will get. Okay, so here you see the treatment of prostate cancer. This is very important treatment. I want you to remember because there are questions directly on this. For T1 and T2A, for T1 and T2A. Now in prostate, one very important thing is the chances of survival, more than 10 years survival. You do active surveillance, just wait and watch, radical prostatectomy or radiotherapy. Okay, if it is less than 10 years survival, then just watch. Okay, less than 10 years survival, watch. T2B or 2C, again more than 10 years survival, radical prostatectomy and radiotherapy. No active surveillance here. Less than 10, watch. T3A, radiotherapy or hormonal therapy or radical prostatectomy depending on the patient's the performance status. No watchful waiting in T3A. Okay, and in T3B and 4, either radiotherapy or hormonal therapy. Basically no surgery in this, no surgery in this. Okay, so hormonal therapy, there are different drugs. Enzalutamide, Degarelix is GnRH antagonist, Goserelin is GnRH analog, new drugs like abiraterone. or you can do orchidectomy also. So basically androgen ablation therapy you are giving here. Okay, so this is very important depending on the stage and the life expectancy. Life expectancy and the stage, you define the treatment. Okay, so staging is important. One more thing I'll tell you about the bladder cancer. Okay, urinary bladder cancer. We know that it is non-invasive and invasive. Non-invasive is when the tumor is limited to the mucosa, it has not gone in the wall. Basically, it is in situ, non-invasive papillary, or T1. T1 is when it is involving lamina propria. So in these cases, we do TURBT, transurethral resection of bladder tumor. Invasive, that is T2 to T4, we do radical cystectomy. Now see, when we do TURBT, then after, to prevent the recurrence, we have to give some chemotherapy or immunotherapy. Okay, so if the patient is low risk means TA tumor, low grade tumor, less than 3 centimeter. In these cases, you will do single instillation of chemotherapy. Single instillation of chemotherapy, like thiotepa or mitomycin C. But in case of high risk patients like TIS, T1 and high grade tumors, you will give immunotherapy. Okay, so see the difference between chemo and immunotherapy. Immunotherapy you will give BCG, and that is given for 1 to 3 years, 1 year minimum. Every 6 weeks you call the patient and fill the bladder with the BCG. After 1 hour, send the patient back. Again after 6 weeks, she will come or he will come, and you do the same thing. But for chemo, you just single instillation immediately after surgery. For BCG, you start 6 weeks, at least 2 weeks after the surgery, and then call the patient every 6 weekly and give the immunotherapy. Okay, so remember, this is important. Now, what else? Testicular cancer. Testicular cancer. The things which you think are different from the notes, after the class, you are most welcome to put your doubts, and we'll see what is the difference you are finding. Sometimes there is some people, they don't write exactly, and sometimes the guidelines changes. Okay, so if your notes are like 1 year back, there might be few changes because of the recent guidelines. What I am telling you is as per the recent NCCN guidelines. Okay, so the first thing is in testicular cancer, you will do a high inguinal orchidectomy. This is the first thing you will do. Now, if it is a seminoma, stage 1 surveillance. Surveillance means follow-up. Stage 2A, you will give radiotherapy. Radiotherapy is given to the para-aortic lymph nodes and the iliac lymph nodes. 2B, 2C and 3, chemotherapy, bleomycin, etoposide and cisplatin. Non-seminomatous germ cell tumor, stage 1 surveillance. Stage 1 is when the tumor is limited to testis. 2A is when there is lymph node involvement less than 2 centimeter. 2B is 2 to 5 centimeter. 2C is more than 5. And 3 is when there is distant metastasis. This is one of the easiest TNM which you can get. Okay, this is one of the easiest. 2A is retroperitoneal lymph node dissection. Okay, so here, because non-seminomatous germ cell tumors are not radio sensitive, so we'll do surgical removal. And same 2B, 2C and 3, chemotherapy. Okay, so testicular TNM, see exactly TNM you need to know about. I told you breast cancer and in this case oral cavity cancer. In the other tumors, if you have a little bit of idea, so that in question if they ask, you have idea like in this stage what should be done, then it is fine. You don't need exact TNM for all the cancers. There are lots of cancers there. So if you have some idea, then it is good enough for other tumors. But for breast and for oral cavity, you need to know about the the proper staging. Bosniak classification, again it is important. One is when there is clear cyst, In 2 there are a thin septa. Risk of malignancy is very minimal in 1 and 2, so we'll do just follow up here. In 2F, there are few fine septas are there, and in this case, basically there is solid and there is enhancement also. So in this case, the risk of malignancy is there, you can say around 5 to 14%. So you need to do proper follow up here. In 3, 50% malignant, there are lots of septations, and there is enhancement and enhancing septations. 4, there is solid component also, and this is definitely malignant. So in 3 and 4, most of the people, they go for surgery. In 2, people, they follow up. 1 and 2 is fine, you can leave these patients also. ESWL for the stone, you know, ESWL is for less than 2 centimeter. Okay, ESWL is for less than 2 centimeter. There are certain stones which cannot be, you know, broken down by this: brucite, hydroxyapatite, calcium oxalate monohydrate, cystine stones. Okay, and also you cannot use this in pregnancy, in the bleeding disorders. You cannot use ESWL. Otherwise, ESWL breaks the stone, and then the stone can pass out. This is PCNL. So for those cases where ESWL is not done, PCNL can be done. Okay, PCNL can be done for stones. Even bigger stones are also taken by PCNL. But remember, bleeding disorder is a contraindication for both PCNL and ESWL. So what to do in those cases? If there is bleeding disorder and you have to do something for this removal for this stone, then we can go for this, which is known as retrograde intrarenal surgery. You will do the ureteroscopy, flexible ureteroscope, and you can come up to the kidney and take out the stone. Okay, so this is done retrograde intrarenal surgery if there is bleeding disorders. Okay, it is something like this. You can see from the ureter you come, and then you can take the stone from here. Now one thing is for large stones in the pelvis, like recently there are questions 4 centimeter, 4.5 centimeter in the pelvis. What is the treatment? You use something known as sandwich therapy. In sandwich therapy, first you do PCNL. Try to break the stone, try to remove as much as possible. The remaining fragments, ESWL is done. Again, if it is anything is left, PCNL. So this is sandwich therapy for large stones, 4 centimeter, 4.5 centimeters. These days, if you ask me what is the indication for open surgery, only if you are going for nephrectomy. Okay, if the stone has caused irreversible renal damage, then if you are doing nephrectomy, then go for surgery. Otherwise, these are the procedures: ESWL, PCNL, retrograde intrarenal surgery. Most of the stones can be taken care by these procedures. Okay, so that is not required. This is one picture which is very commonly asked in the AIMS exam. This is fracture penis. Fracture penis, where there is injury to the tunica albuginea. There is only one treatment, that you need to do surgery. There is no conservative management. You will see the surgery. There is this defect in the tunica albuginea, and you just suture the defect. Okay, so these are the important things I know I was very, very fast because of the time. I could not give much time, and but this was must-know topics. So this is just to tell you the topics you need to read. Okay, this was not a proper class, so that's why I guess if I finish in the time, that is more important rather than going in detail of each and everything. So this is about this, and any controversy, like most of the people they are saying there is some controversy in the notes and all, you can free to ask. You can tag me in the group. Okay, in the Facebook on the DAMS exclusive club, you can tag me, and if there is any controversy, we'll discuss, like all the faculties of the surgery. If there is any controversy, then we discuss among us, and then we see the recent guidelines finding, and then we tell the things, so that you are at gain and you should not take the wrong message and the wrong answer. So we'll discuss, and then we'll let you know if there is any controversy, if there is anything which is there. PDF will be provided to you. Don't worry. Go through the PDF. Okay, like when you have time and you go through the PDF, see the things, see the staging, see the treatment option. If there is anything, any controversy, anything which you could not understand, you're free to ask. And in that chat, we can have like more detailed discussion rather than like in this class because of the time. Okay, so Urethral injuries, one important thing about urethral injury, just remember that recently ATLS has said that the per rectal examination in which when there is injury to the membranous urethra, you find that the high riding prostate, that is not a very sensitive sign. So just remember, high riding prostate is not important now for urethral injury. It is not a sensitive sign. It is no more done. Per rectal examination in urethral injury is no more done. Okay, then the treatment is very simple. First you do a suprapubic cystostomy and later on do a retrograde urethrogram, see the injury, and then later on you do the repair. Okay, so if there is anything, any question which is there, I mean question, because we are already late, so we cannot discuss much. So we'll finish this session now, and controversies, doubts, always welcome, and other people are also waiting, so you'll get all this PDF. Okay, so thank you very much. In the exam, remember that read the question twice. That you are not, there is lots of time in the exam. Okay, you are not going to leave any question without reading. So give some time to the surgery questions, because the questions will be clinical. Clinical questions are more easy. Image-based questions are more easy. There are lots of information. I'm sure you will come to the correct answer. Okay, just when you read the question, when you read the option, you will have, like, the answer will, you know, it is shining in front of you. After, when you go prepared, the option is shining in front of you. You can easily mark. Even after marking, just check once again the question if there is any minor detail which you are leaving. Okay, so thank you very much, and best of luck. God bless you, and we'll be in contact through those chat and social medias. Okay, thank you.